Ladies and gentlemen, please welcome to the stage Foreign Policy's publisher and CEO, Andrew Solinger.
Good afternoon, everyone. Thank you very much. Because it's getting into the late afternoon, we'll do a call and response. Good afternoon, everyone. All right, that's very good. We bring the energy up. We still have folks trickling in, but we want to kick off and remain on time. Welcome to part two of our Global Health Forum here at UNGA, FP's Global Health Forum. We're going to be focusing on resilient health systems. And one of the key themes we want to explore today for you here in the audience in person, as well as the many folks who are tuned in online, is that health must be reframed as a long-term investment, one that drives prosperity, productivity, and economic growth. It is not a cost that needs to be cut. And as a result, we need to come up with innovative financing and partnerships that can help build on that investment and create that growth and scale solutions globally. There's lots of emerging innovations, women's health data, decarbonization strategies that show how investing in health can also advance equity. So we want to talk about that too. So we have a lot of these discussions that are going to take place today. It's going to be a very interesting conversation. A few housekeeping notes before we begin. There is a lot of stuff on your chair. There is a card with a couple of QR codes on it. On one side, we'll take you to our agenda and the biographies of all our excellent speakers. Please do click through and check that out. On the other side, you can subscribe to Foreign Policy. Why get all this great information in one sitting when you can enjoy it each day, every day, all year long? You have an example of that journalism in printed format, the magazine that we produce, this one on the future of development. We still do a quarterly print magazine, but we are primarily digital. We do fantastic digital content all day long. So please do subscribe. It will support FP and help us do programming like this. And actually, if you subscribe today on site, or if you already have a subscription, see my colleague Corinne outside, and you can get a very cool hat that has the Soft Power logo on the front. And not a lot of people know this, but Joseph Nye, the dearly departed Joseph Nye, a famous professor and geopolitical theoretician, coined the term soft power in the pages of Foreign Policy something like 25 years ago. So that's in his blessed memory. And get a sub, get a hat. It's a great deal. I also, most importantly, want to thank our partners. Today's event was made possible with the help of Lilly and the Gates Foundation, with additional support from Food for the Hungry, McKinsey Health Institute, Reckitt, and Sanofi. So we've got a lot to cover today. We're going to dive right into it, and let's get started.
Next, please welcome McKinsey Health Institute Senior Partner, Dr. Pooja Kumar, Roche Vice President and Head of Global Access Policy, Tamara Schudel, and Inter-American Development Bank Vice President for Finance and Administration, Gabriel Yorio, for a conversation with FP's Andrew Solinger.
Somehow I think I screwed that seating up, but we're okay. We're all sitting, and I think we can have a conversation. So we're going to talk about investing in health and making the economic case for smarter health investments. I mean, this is really the key topic that we're here to discuss today. In a time of economic distress, and when there's a lot of protectionism and a lot of concern about debt burdens globally, it is normal for governments and organizations to look at their finances and think, where can I squeeze, cut back? Where can I control my costs? Doing that in the realm, and that's a good idea, but doing that in the realm of healthcare is not such a good idea. We need to start thinking about health as a way that we can actually boost economic growth. An investment in health yields dividends. And that's one of the subjects that we want to dive into with this excellent panel that we have right here. Dr. Pooja Kumar, Senior Partner of McKinsey Health Institute on the far left. Tamara Schudel, Vice President and Head of Global Access Policy at Roche. And Gabriel Yorio, Vice President for Finance and Administration of the Inter-American Development Bank, there for about a year, almost, most recently, though, with the Mexican government, and can give us some real-life examples of both what it's like on that side of the fence in terms of managing those finances, and also how we can do better financing regionally and globally. So thanks, all three of you, for joining. Pooja, I would love to start with you on how we can really let's just tackle that top topic. How can we take health from being a cost to being an investment and an economic benefit.
Yeah, thanks, Andrew. And I think you said it best when you can look at it as a cost, or you can look at the bigger picture, which is what is the return that we're actually getting on that. And how many of you have been to a doctor in your life? In your life.
Come on,
How many of you have been in the last year, for example? Right. Many of us know, right, there's immediate social return, a personal return, when you get the care that you need at a time that you need. And I know it's a totally separate issue if you're getting it when and where you need it, but we feel it intrinsically. What we've been working on doing, Andrew, is to actually quantify what does that actually look like and what is the economic return, so that we can talk in terms of all of the stakeholders that need to be brought along with regards to health. You know, it's a conversation that we should not just be having with folks who are health-oriented and ministers of health, but really we need to be having with ministers of finance and a broad range of others. So we recently published a paper on exactly this. So if we look at non-communicable diseases in particular, addressing NCDs could actually prevent up to 28 million deaths annually if we did it right. And this is with known interventions. Okay, so 28 million deaths. And also, in doing so, add $11 trillion to the global GDP by 2050. So it's a clear health argument in terms of lives saved, and it's a clear economic argument in terms of what we're actually able to add to the economy if we take this seriously and work on interventions that we know to be effective.
So that sounds like an absolute no-brainer. Let's just do it. Easier said than done.
That's right.
Tamara, what are some of the blockers to this? I wouldn't call it obvious, but it is very clear. The data is very accurate. It makes a lot of sense.
That's right.
More workers, more economic development, better returns. What are the blockers?
That's right. I mean, some of it has been touched upon already. One, it's this mindset that we've had for a long time that healthcare is a cost center, right? And if we look at the rise of disease and aging populations, it is overwhelming for many governments to think, how do we finance this and how do we finance it sustainably? So one of the challenges is that we've been looking at health in a silo. And it is not only a health issue, it is not an issue of hospitals and health systems, it is an economic issue, it is a societal issue. To Pooja's point, if you get the care you need and you're healthy, you can go back to work. You can be a productive member of society. You're again a taxpayer. You can be a caregiver to your children, to the elderly. It doesn't matter what it is. And we fail to capture that effectively, to quantify it, and to have those discussions cross-government. This is shifting. It's a slow shift, but it's good that we're starting. And it is a whole of government approach. It is not only the Minister of Health's job to figure it out. In fact, I think they need the most help because they work with the budgets they get. It's looking at the head of state level to put it into the broader economic and societal perspective of countries. It is looking at also how do we bridge it beyond short political cycles, because we know those influence how some of the decisions are made. And instead of fighting year by year for health budgets, if we could think differently on how to make a case for multi-year budgets, so we can really focus on longer term outcomes and not have this short-term pressure.
Great. This is where I have to plug a research paper that we've done with Roche on investing in health. This is Foreign Policy Analytics has put together this insight brief, which I believe you'll be able to find on the streaming page if you click online. And we will distribute that to everyone after this event. And you can see some details specifically on technological advancement yielding, this is focused on technology, yielding immense benefit to society. So thank you for bringing that up. And thank you to the Foreign Policy Analytics team for pulling together that excellent brief. Gabriel, would love to come to you now. Let's talk a little bit about, and let's put the IDB aside for a moment. Let's go back to your time in the Mexican government. Maybe you could give us kind of a real-life perspective on how you view this cost versus investment dynamic in Mexico and in other countries that you're familiar with.
No, sure. And thank you for inviting me for the opportunity to share this experience. Well, usually when you are in the Ministry of Finance, you are facing all the time budget competition. Several line ministers are competing for the available resources. And it's when the Ministry of Finance needs to find innovative ways to provide not only budget, but also to work on financial solutions. In Mexico, we did both. We have the health system that is incorporated in the central government, But also we provided some market solutions so we can provide, so we can mobilize resources from the private sector and public sector to have multiplier effects. One way we did that is in 2-3 years ago, we issued the first SDG-linked bond, the Sustainable Development Bond. We issued it, we built a framework in Mexico. We issued the bond. It's an impact bond that we issued in Europe first and then the United States. But we managed to raise $21 billion. 1/3 of that was devoted for health system. It's not enough, but at least we managed to get the markets closer to the government, the public policy, and also to develop specific reports that we were supported by the UN at the time, that get the highest commitment with the investors community. And that's one way we make a case for continuing investing in the sector. So that's one way to do it. So from my perspective, sometimes people that is in the government is fighting for the budget. There are financial dimensions as well that can be used to leverage investments, not only because from the public sector, but also from the private sector.
Well, let's definitely get back into that financing in a minute. But just a follow-on question, is an SDG bond a popular securitized vehicle?
It wasn't that popular at the time. Now it is. We have practically, that's the framework in which Mexico is issuing sustainable bonds in international and local markets. And I think that's also a nice way to incorporate long-term commitments that the government can have with the investor and also with the beneficiaries of the system, not only in terms of health system, but also in other public services. Let me just finish with one comparison. Long time ago, we were talking about sustainability and green financing. All that was related to energy or green policies. Now, when we talk about sustainability, we also bring the social dimensions there and the social gaps that we're facing in the governments. And health is one of them. So that part of that framework, I think now is beneficial for the government.
Great, very cool. We'll come back to that a little bit later. And also, I like what you were saying about having the better long-term approach rather than living budget cycle to budget cycle, which some countries do too much. Pooja, I would love to get back. You started talking about some of the data that you have come up with, and I know that there's a McKinsey research data point. Every $1 invested in health systems, and you referenced this, is a lot more money in return. Where are the gaps that you see right now in realizing these returns? Is any particular sectors, or we're talking about health, as a giant, big monolith. Are there areas and elements? And you mentioned preventing NCDs as an example. Where are the gaps that we can kind of prioritize to focus on?
Yeah, we've had a particular focus on NCDs this year because of this simple fact that I think if you look at any of us in this room, right, most of us, all of us, I think would choose not to get sick in the first place versus, having effective treatment once we already get sick. And back to the ROI point, there is so much data that also shows that we actually have known interventions focusing on prevention that are difficult to scale, but are eminently scalable if we find the resourcing and the right operational backbone to put behind it. And the ROI, by the way, just to be very clear, it's 4-to-1 that we calculated on this. So I think what I would say is there are the WHO, Best Buys is a great starting point, right, for some of this. There are specific interventions, whether it's tobacco cessation programming or HPV vaccines, that are highly, highly effective with multiple case studies and case studies at scale, not just, pilots, right? Because I think the other failure mode here that we see often is the small pilots. But we have real case studies of scaled ability to change the curve of health in some of these subpopulations. So we're particularly excited about NCDs. I did want to call out also mental health in particular as an area that historically we've been very underinvested in, historically and currently, actually, we've been very underinvested in, which we think is particularly important. And again, looking at a person's whole health, right? I don't think any of us here would say oh, it's only just about how my body is physically. There's also a lot of evidence that mental health conditions and a person's mental health is a really big determinant of their physical health also. So there's an interaction variable between those two as well.
That's a great call out, and we had some discussions in our last program about mental health as well, and we're seeing an increased focus on that, especially since the pandemic and a lot of the impacts that took place there. I think it really elevated the conversations. That's a really good point, and undermeasured and underserved. Tamara, I was wondering if we could put on your industry hat a little bit here. Roche, correct me if I'm wrong, does a lot of investment in low and middle income countries, whether it's investing in infrastructure or partnerships. You've got to measure the value of those investments above and beyond economic impact, on economic impact, not just clinical outcomes. Maybe you could tell us a little bit about the measurements that you guys put in place when you're making those types of investments.
Absolutely. Well, first of all, just to say I agree, prevention is the place to start. And we know what can be prevented should be prevented, and that is the best return on investment. And while McKinsey looks at collecting data and return on investment for health, at Roche, what we've been doing is looking at that impact on innovative medicine specifically, also diagnostics. We're a healthcare company that does both, but looking at if you can prevent, how can you make sure that you're using whatever budget you're putting in? It's not always about more money. It's about better use of the money you even put into the system. Absolutely. So if you're looking at the money you have, if you can screen and diagnose and catch disease early and treat it with standard of care, that is a great return on investment. So we've been collecting data, and I can give you an example of HER2-positive breast cancer. From the data we've collected, it basically says if you catch disease early, it yields a 20% economic and health impact than if you catch the disease late. Mm-hmm. And after 8 years, we have patients that are living cancer-free. So think about what that means. Not being on treatment, not being in hospital, not being sick, not feeling bad, but being able to go back to your life and being a productive member of society. If you catch it late, you're not only spending resources, which won't yield, but you're also having meaningless outcomes for the patient in the long run. So this is one of the things we've been looking at. What that requires for all countries is to make sure that they're also seeing innovation as an investment. And over the years, especially post-COVID in health, but also in innovation, we've seen cost containment and cost cutting exercises because we're so focused on short-term problems. And we need to be shifting that perspective to looking at long-term impact. And that's essential for an innovative sector like ours that works on very long timelines. We need proper investment. We need proper certainty to be able to take riskier investments. And we can talk a little bit about that later as well.
Sounds like we need more SDG bonds, perhaps, Gabriel. Maybe we could put on your IDB hat now, the hat you're wearing, or keep your IDB hat on. You often fund multi-sectoral development projects that touch a lot of areas of development. How do you integrate health in there when even within those micro development projects, it's easier to say, yeah, but this infrastructure, this road, this plant, this equipment, this airport will bring more economic development?
Yeah, no, health is one of the most important sectors that we are supporting at the IDB. The IDB is the main development partner in Latin America and the Caribbean countries. We have an outstanding credit portfolio of around 120 billion, and as for now, we have almost developed 7 billion direct investments in the region for health and 1.8 billion in terms of technical cooperations to design public policy or to design reforms that can be implemented in Latin America. But still, the region falls short when we are investing in health. No? Latin America invests around 4% of public spending in health compared to 8% of the OECD countries. It really falls short. And also there is an issue important, trying to tackle in a cross-cutting way all support that we provide in the region is that we are trying to ring fence also when families are exposed to risk. And health is one of the risks that they are exposed, especially for low-income households. The health-related cost of an economy usually falls in 1/3 on Latin American households, and that compares to 20% of the OECD households. That means that the risk of falling into poverty because you have suddenly experiencing a chronic disease or a disastrous disease that will require the family to seeks support or seeks the services on the private sector can actually erode wellness, can erode well-being, can erode prosperity in our economy, in the economy. So the IDB, it's practically is of the utmost importance to invest in health. We do it in a cross-cutting way. We are supporting governments with lending, also with guarantees to mobilize private resources. But we have two specific private arms. IDB Invest lends directly to the firms, to private sector. And we have IDB Lab that seeks or looks for startups or unicorns in Latin America that are investing in innovation in technology. That's important because technology is part of the incrementing cost in health right now and inflationary that we are perceiving. So the IDB is trying to tackle both and to provide innovative solutions, financially innovative solutions in that sense.
That's very cool, and especially doing that on the development startup end. And what kind of moderator would I be if I didn't bring up AI in our discussion on anything, but especially when it comes to health? And Pooja, maybe you could help us out here. There's lots of different digital health, AI, data analytics that can help here, expedite the process. Maybe you could pick one and dive into that and tell us what the opportunity is. What has the strongest evidence for delivering highest returns?
Well, I don't know if you've heard, but AI is going to solve everything.
It is. Already is.
There's not just, no, I'm just kidding. Already is, yes. But, probably AI is as good as what you give it to work on. And even then, right? Even then, we'll see. So I think there's two parts of your question. I will first just start with data, because I think we're also just vastly underutilizing, a data-driven approach to health. Much less AI. Like, we don't even need AI, right, for half of what I think we could probably be doing. Right. So I talked a little bit about how do we make the economic case for health, for example. How do we just do this on a more consistent basis, right? Every time we talk about health, can we talk about the return? And what is a better return? Like, we should actually measure that. We should be able to back our statements up with data. We should have the transparent comparative conversation on other priorities. That being said, I do think, over time, like, AI will likely have some utility in this space. One use case, for example, that we are just starting to think about is, okay, if we have the budget for health, how do we make sure it's actually best utilized, right? How do we ensure it's going to the intended recipient? How do we make sure there's less waste and that every dollar that's allocated is allocated to its best use? And I think that is something where you could use AI to actually track real-time spending, for example. You can follow the dollars and actually even early probably catch areas where maybe they're not being as utilized as they should rightfully be. So that's just one, use case, and I'm sure there are many more on that road to it taking over entirely.
Sure there are as well. Tamara, maybe to look at, I also wanted to talk about different types of structures, so public-private partnerships and how those work. What are the best structures that can be put in place to take the best advantage of this moment and prove the best economic benefit? I don't know if there's a type that you might explain, or an example that you might give of one that's impressed you that you think works well.
Well, there's plenty. What we have to realize is that this challenge is too big for any one stakeholder to manage. And if we're all bringing our best competency, what we're individually positioned to best contribute to challenges faced in healthcare, and creating partnerships that can enable that system to work, that is fundamental. For an innovative company, we innovated medicines. That's our core purpose. However, we know that those medicines are only meaningful if they reach the patients that actually can benefit from them. And this is why we spend a lot of time on health system strengthening and policy work to make sure that policymakers understand why access to these innovations is critical, not just in treating the health problem, but again, looking at this from a strategic, economic, and societal value. For that, we need solid structures in countries, certainty. We need robust systems that protect innovation, that protect intellectual property.
IP protection.
IP protection is critical. Today, I mentioned HER2 breast cancer, the standard of care, the treatment that's saving lives, curing disease. It took 30 years to get there. With many iterations, high-risk investments, I wish, you can press a button with AI or whatever and get one day to the next, and maybe we can accelerate those timelines. But it is a risky, long business. So we need systems and structures that really support and spur that innovation. We still have so many unmet medical needs. As a society, we want to see cures, certain diseases. We want to see better treatments for others. That's going to require investment in innovation. So one of the things that we're working with partners and governments alike is to also make sure they understand life sciences is a strategic sector. It's a strategic sector like any other industry where it contributes to your economic growth and economic prosperity and societal contribution, and not just health service delivery. But obviously, we do a lot of programs in countries all over the world, developed countries, low and middle income countries, to make sure that we can accelerate those systems to be able to not only support innovation, but actually adopt it.
Okay, great. Gabriel, you had mentioned, it'd be interesting to kind of talk about what financial structures you think work well, and examples of that. You brought up SDG bonds in Mexico. You talked about some venture capital investments that IDB makes. What financial structures do you think are most ideal for delivering economic benefit from health investments? I don't know if there's a model that you would care to share, or one that you're looking at that you haven't done even.
Well, I'm not sure if there are like a specific solution. I guess depending on what we would like to achieve, we will find different financial innovations. Let me just put an example. For example, we have a different level of development in Latin America. Some of the countries have market access. Some others depend more on MDB's financing. Some of them have debt distress. So, for example, one of the schemes that we are evaluating now, probably you have heard about the debt for nature swaps that we have done, exchanging debt for nature. That's something that we can replicate in debt for health or debt for care, for example, when we think on the care system as well. That's one of the solutions that might be deployed when we are thinking on countries that already have some debt that is kind of distressed in the market, and they are not right now subjects for credit.
Maybe you could just describe debt for nature for someone who's not familiar with.
For someone who's not familiar, you have a bond issuance in the market. You're paying interest rates, so what you do is a swap with the investors. You reduce the interest rate, and that savings is devoted for investing in some specific infrastructure. Debt for nature is for nature. It could be for other kind of purposes. If we start talking of debt for health, that could be used for health, for the health system or health investment from the public sector government. But when we're thinking on mobilizing private sector as well, guarantees is a very efficient tool because it reduces risk. It provides. It opened the access to the private sector that want to engage in these investments, and that way you can have more multi-factor effects on the economy and the investment. So you don't use your whole budget on that. You can actually share risk with the private sector. So it will depend. I don't have a favorite.
You have a cool job, though. You're going to develop very cool financing mechanisms. Maybe we could go to Pooja and then Tamara, and kind of a similar question. If you were to pick one investment today, and you've kind of hinted at a couple, what would it be? So that is one investment today that would deliver the biggest combination of economic benefit and health benefit.
I'm going to have to go with SDG bond towards prevention. I think prevention is my one investment.
Yeah.
Understanding that it is not just a single intervention type, but I do think it's an intervention bundle that we have evidence works. We have mechanisms to finance, and we can prioritize. What would you say?
Well, for me, it would be investment in innovation, innovative therapies, and to make sure that we're better at collecting and communicating about the return on what it means to have an innovative standard of care treatment. As I mentioned, as Roche, we're partnering with Vifor to collect that data in hopes that when we have governments assessing what that intervention means, they're looking at it from a broader economic and societal perspective and not just on the healthcare delivery. And I'll just give you a data example because you did ask for examples. We looked at 10 economies, so G7 plus China, Brazil, and Spain. And we applied that to some of our innovative medicines. So for multiple sclerosis alone, we contribute that nearly 27 billion will be in economic growth across these 10 economies, just due to one of our innovations for these patients with multiple sclerosis. And these are things we haven't done well in measuring and communicating, and we need to all be better at looking at this systematically.
Great. Well, I think we're out of time now, so I think we'll end it there. But some really encouraging. We've heard a lot of terrible things, by the way, earlier today on where we are, the state of play with governance, with every country's not acting in unison. It's very encouraging to hear about innovative financing mechanisms, innovation in medicine, and prevention that will help boost economic growth. It's very hopeful. So thank you very much. We really appreciate it. Please help me thank our panelists.
Please now welcome the Alliance for Health Policy and Systems Research Chair and former Prime Minister of New Zealand, the Right Honourable Helen Clark, and Reckitt Chief Communications and Corporate Affairs Officer, Sheila Redzepi, for a conversation with journalist Maggie Lake.
Hi there, everyone. Helen will be joining us. You all can sympathize with UNGA traffic and getting around New York, so she'll be here very shortly. We hope to be able to join this conversation. But we are going to continue the very uplifting messaging that we heard and hopeful tone in the last panel and talk about something similar, but we're going to step back in the time frame. So not only talking about how we can shift the conversation around care from cost to an investment opportunity, but prevention in particular, which is super exciting. So thank you so much for being here. So let's just pick right up. How do you think that we can shift this conversation, and why is the prevention part of it so important?
Yeah, thank you so much, Maggie. That's a great question and a great way to start. And it was very insightful to hear from the panel that was just before us articulating some of the very important messages that we will do as well as part of our conversation. We're part of a health system that's under severe pressure. From chronic disease and aging population, and of course with climate change pressures and natural and weather disasters, these pressures are only becoming bigger. So we're part of that system. It affects our health outcomes, it affects well-being, and ultimately comes with a cost. So we teamed up with a group of wonderful people, Yale School of Public Health, Resilient Cities Network, Bupa and Sanofi, through our work with the Sustainable Markets Initiative, and found very quickly as part of that research that even very modest interventions in prevention have significant outcomes. We are looking at 700,000 lives saved a year, $70 billion cost savings, and then significant reduction in emissions. Because we also have to look at it from, healthcare systems also contribute to carbon emissions. So interventions in prevention have significant output from cost, lives saved, and emissions reduced. So maybe another way to look at it, Maggie, is it is prevention, but it's also about building resilience, building preparedness, and making sure that we can adjust and adapt to ever-changing circumstances in our environment that ultimately affects health outcomes for all of us.
I like the concept of resilience when we talk about that in the private sector with companies. When they're talking about resilience, I often hear them say we're future-proofing our company. We need to think about societally doing the same because they know, and they're able to get investment because they know that if they don't, it will cost them later, not only straight out cost, but from a competitive point of view. Yeah. So it makes sense that we should use that framework, and maybe that language is really helpful. One of the things that always comes up when we talk about prevention, and we've heard it in almost every conversation we've had today, early action or prevention has come up in almost every one. It seems so obvious. Yeah. Why do we have to talk about making an economic case for something that I think we all inherently know makes sense?
Yeah, you're absolutely right. It is also, as human beings, we have adjusted and adapted to our environment over time. It's intuitive, it's instinctive to do that. Prevention is always better than cure. Of course, we have to do both, and we're faced with different challenges. But in an environment where you have converging and competing pressures, it's incredibly important to articulate both the gains, but also the reduction in risk, the reduction in cost, because it comes with multiple benefits. And so yes, maybe perhaps because it is so obvious and so intuitive and instinctive, we don't take the time to articulate the data for those that have to make some of those very tough decisions in a situation where you're looking at competing and converging crises happening all at the same time.
I think that's really important. That's why we talk about this intersection of climate with healthcare, because it is difficult if you're on the front line. Prevention is something that you have to plan for, right? You're asking them to make an investment now for something that will come, or maybe, hopefully not, later, to prevent something from happening. And when they're besieged by the current crises, that complicates the conversation, I suppose.
Completely. And that's one of the reasons why, we have looked at cities. They're at the front line of where all of this happens. You start to put some numbers to it. 7 out of 10 people in the world are going to be living in urban environments by 2050. So you kind of have to get it right in places where you're feeling the immediate pressures of climate change, changes in health outcomes, pressures on our immediate environment that shapes the way, the way we approach health. So we listen to cities and we talk to them, and as part of that work, you very quickly begin to realize that they're aware of the issues, but the challenge is, of course, how do you make those, how do you prioritize? What are some of the practical tools that they can deploy that will help them make those decisions? What are the preventative actions? What does that toolkit look like? How do you pilot some of these programs? Who's doing it well so we can talk to them and do exactly the same? So, as part of this work, then we very quickly realized there is merit in that kind of coordination. So we convened a community of practice across 29 cities in 19 countries whose sole purpose is to exchange some of these ideas. How do we approach data? How do we, how have you done it in the city of Glasgow, and what can be done in Rio or Mexico? And you find very quickly that that's exactly the kind of work that we ought to be supporting with, because cities are really on the front line of some of these immediate challenges, and they have the tools and resources oftentimes, but the question is, how do you deploy them, when, what are the right interventions, and where has it worked well?
And we need those case studies, the best in class. Helen, welcome. Thank you very much. We said we all sympathize with getting around New York City during the UN, so I'm glad you were able to make it. Let's sort of have you weigh in on this conversation, because I know you think about it all the time. We sort of started out by saying, trying to shift the conversation around prevention as an investment opportunity, not just a cost, seems so obvious. Why do we have to keep making the case? What's standing in the way when it seems like this is such an obvious solution and something we should be doing?
So in my relative youth, I was a health minister. And what I know is that our publics are mainly focused on whether they have access to services. Can I get to the doctor? Can I afford the doctor? Can I afford to pick up things at the pharmacy? If I have to have an operation in the public hospital, is the queue too long? Will I die before I get treatment? So the public tends to be, not, and this is not a judgment on it, they tend to be focused on whether those sickness services are going to be there. So to invest in prevention, you're trying to find money to do things that will get you on the front foot and support people to be have healthier, longer lives. But, every dollar you put into that obviously is something that's coming off, the money that might have reduced the waiting list or whatever. So that is the political problem in a nutshell. And I've seen it play out in my time as Minister of Health and also as Prime Minister supporting a health minister. But that shouldn't put us off doing the right thing and making the case. And I recall back in 89, 90 when I was a minister and very focused on these issues and going to the World Health Assembly, issuing 10 New Zealand health goals, which all dealt with preventable non-communicable diseases, but they needed investment and they needed new policy and regulation. So right now, we're asking people to make the case for investment in prevention at a time when government budgets from the highest income countries to the lowest are under a lot of pressure for the whole range of reasons we don't need to discuss here. But, the COVID left a lot of countries stripped out. People are trying to move back towards balancing their budgets. So, every dollar becomes very scarce. And that's one of many reasons why, I add my voice at meetings around this town this weekend on other occasions to saying that this is the time for those health taxes to raise some money and get it into the areas you're trying to, get prevention on. So if you're taxing tobacco adequately, you can mount the campaigns against that. If you're taxing alcohol, if you're taxing the sugary beverages, I mean, this is good for health and it's good for the revenue. Over time, one hopes that it being good for health will lead to substantially reduced consumption. But, obviously there's a lag where you're going to be getting the revenue in. So I think, that this is exactly the time for that. But, let's not just dismiss the political obstacles to investing in prevention where people are, really wanting their treatments because they're sick. And we haven't had time to prevent what, might have been preventable.
Yeah, well, and right to point that out, and we have to operate in reality right now, and it's happening everywhere. It's governments, it's multilaterals. Everyone's having to look at their budget, as we discussed earlier with UNGA80. What role? So two things. What role does innovation play here? And we're talking about tackling not just health now, but also climate, which is a more immediate problem that has to be solved. How does innovation play in? And if we're talking about multiple goals, can we get more stakeholders or shareholders involved in that conversation?
Well, if you take multiple goals and you're encouraging people to live healthier lifestyles, where this is possible, walking and cycling have great benefits. They also have the benefit of taking cars off the road. And, you walk around New York. I'm not seeing too many electric vehicles, by the way, but if I was, they'd probably be powered by, some fossil fuel plant somewhere. So, so we'd get a big win for people's health, for taking burden off the health system, and for taking burden off the climate if we could move people to more, active transport, as we call it, which is using your own two legs. As I say, where that is possible. Now, it is possible in New York, even on the hottest and most humid of days, but I'm very conscious that, a significant number of people in our world live in places where it's very hard to walk because the heat is so extreme and getting worse with the climate crisis. So, other solutions there, obviously. But we can find win-wins for sure.
Yeah, which is helpful. Sheila, you talked about practical tips. By the way, when we were talking about heat earlier, we had the official from Rio de Janeiro saying, there's no one in charge of heat, right? There's no department head for heat. So you have to have this collaboration between many different officials. You mentioned cities really being at the forefront of this and an interesting example. What kind of practical toolkits are you talking about? How can we use examples that are working and help scale that?
I want to also pick up on the Prime Minister's mention of walking and our change in urban lifestyles. I mean, it has a huge impact, and believe it or not, as simple as it may be, that too is a recommendation, and that too saves lives, reduces emissions, and there are quite a few other benefits associated with it. So as we were, part of the work I mentioned, the community of practice that gathers cities around the world, their chief resilience officers in some cases who are part of these conversations. One of the things that we have made available is a group of health and climate experts who have looked at very practical interventions. What are the very practical things that we can all do that will have that triple impact, reduce emissions, improve health outcomes, and cut costs? And if we can get all of those, that's a pretty good outcome on multiple fronts. And that doesn't just affect one department or one ministry. It has cross-cutting implications. So you look at things like, yes, changes in lifestyle habits, healthier lifestyle in urban environments, and in cities, that's particularly important. Cities are struggling with air pollution and heat stress, as we might have been over the last couple of days as well. There are very simple things that are widely deployed, like green roofing. I mean, they have looked at very successful and simple, practical, tangible examples of things that can be done that can have a direct impact on reducing the impact of pollution and heat stress on human health and on emissions. So there are several such examples, but also improvements to water infrastructure upgrades, because that alone, we've articulated some significant numbers in terms of health outcomes that are directly associated with improvements made to water infrastructure. And early warning systems as it comes to natural disasters, these all yield significant benefit that both reduces cost on one side and extends human life and well-being, which is ultimately what we would all want to see happen.
Yeah, I mean, let's give a shout out to our mayors and cities who really work on these things in an integrated way. And one of the greatest examples, I think, is from New York City itself. I think of Mayor Bloomberg's time when Jeanette Sadiq Khan was the transport commissioner. By Jove, so she makes some changes around the place with the bike lanes and, more pedestrian precincts and really encouraging the active transport, and had the full support and backing of the mayor. That's leadership. So it does have all these triple wins that we're talking about.
Yeah. Speaking of that sort of leadership, talk to me a little bit about the importance of public-private partnerships. We just talked about how stressed the sort of a local budget might be, or the strains on healthcare system. Anytime we have these conversations, it seems that that's a critical part of this. What can be done in that area to help shift the conversation more about the investments needed, especially since they're a little bit of a longer time frame, which can be hard? Helen, any thoughts on that?
Well, I mean, some thoughts. I mean, it could be, are there opportunities for the public-private partnerships and some of the infrastructure that's needed for the active transport, for example, because this doesn't come without cost. I know, because I watched the debate in Auckland City in New Zealand where I live. It costs to put in bike lanes and proper, pedestrian, precincts and so on. So, is there scope for, for the private partnerships in that area? Secondly, you have in the private sector, significant companies which have a major interest in, for example, active transport. I mean, what are the trainers we wear? People who really want to promote people getting out there and doing active things. So I think that there's two ways it could go. It could be one, that the company is a purveyor of products which are very positive for health and climate. Or secondly, it could be investment opportunities in the infrastructure needed to get this right.
Sheila, innovation, it's come up. We said we haven't done a panel yet where we haven't talked about AI. Can technology help in that cost analysis, and especially when it comes to prevention? We know in diagnosis, we were talking about it. In treatment, we're talking about it. What about in prevention?
Absolutely. You will find the benefit everywhere as we're learning every day. We're discovering new uses and new opportunities with AI. One of the things, again, we're listening to the cities as part of this effort. What are cities telling us? What do they need? What are they learning? And what are they seeing? Some of them use, and this is more technology, but AI certainly helps with that. We were talking to, the city of Glasgow, for example, use health inequity data to map particular interventions that would help assist with, the city's response to these multiple converging crises. Other cities who are weighing in with similar examples of what they have done with good data and good, in terms of early warning systems. I mean, there is some ability to predict certain events, and AI can play a role in all of that. But what's interesting is that people are faced with very similar circumstances. Sharing in communities of practice can bring out some of those solutions and, add scale to them.
And scale is always the issue here. Helen, based on your experience, what strategies can help make sure that prevention is embedded into healthcare systems?
Well, I think it takes leadership, actually. I mean, the case for it is so clear, right? But it doesn't get done for some of the reasons I've been talking about. So it really needs the encouragement of leaders to step out and make this a priority. That if you only ever have the ambulance positioned at the bottom of the cliff, it's going to be very busy. So let's build the fence at the top where people don't go lemming-like over into entirely preventable and avoidable disease. That's the perspective that leaders need to apply to this.
Yeah, well said. I like the.
I think it's really hard to say it any better than that. It's such a memorable analogy. I might have to use it, but it applies to everything. Same with natural disasters and accidents, preventable health issues. We talked about health and well-being and lifestyle. There are a lot of things where that same model applies. Now, are we wired to think for the future versus for the immediate challenges and crises we're faced with today? That's probably a shift in narrative that has to happen. But I do think there's something to be said about prevention and resilience. Resilience is really building for a better way to do things in the future, and that might be something that creates additional momentum on the ground to really invest in preventative solutions.
This is also where data helps, right? We were talking about technology, but all the work that you're doing with the report and the organizations you're working with. We heard McKinsey earlier, just gathering all the data to make the use case of investing in prevention is going to help. It's evidence-based, so it certainly helps.
But in general, I think the point being made is know your risk, whether it's your risk to your health as an individual, whether it's your risk as a community, a city, a municipality to natural disaster exacerbated by climate change, but other forms as well. Know your risk with reference to how you prepare for a pandemic. Right now on the level of information we've got, we'd probably be preparing for one on the basis that it was COVID, like we prepared for COVID on the basis that it was flu, which didn't help. We had to throw out those plans, get a new one. So if we're really going to be properly prepared across the range of threats that we face to ourselves or our societies or economies, we have to know our risk. Now, this is where I think we can get a lot of insights from the insurance industry, because they know risk, right? That's why they're such a big voice on climate risk, because who's going to be paying out? Well, the insurance companies, but if they're paying out a lot more, then the person being insured is going to have to pay a lot more, and that becomes more unaffordable, and you get a vicious negative cycle. So I think investing again sort of way at the back of the spectrum on knowing our risk is so critical.
It's interesting you say that, because in other areas, the insurance industry is looking to be more involved in investment conversations earlier on and not just after, when you're trying to worry about it. Makes perfect sense for the reason you said. If we could close with each of you just giving us a thought about what you would like the audience to take away from this. What needs to happen in order to make sure that we are properly investing in prevention? Prime Minister?
Well, again, I always stress the value of leadership, that leaders need to step up and lead on these critical issues. And secondly, I think from the way we've been describing it, often the solutions are not that difficult or technical, right? What a city can do to make it more livable, more walkers, cyclist friendly, the air cleaner, it's not rocket science. So, I mean, innovation always helps, and I'm an addict to the Fitbit, like probably many people here. Know your risks, know what you're doing, but it's not rocket science.
Wonderfully put again. I think two things really. We're all part of the environment. We're part of the environment shapes our health. The air we breathe, the food we eat, it shapes our health outcomes. So we're part of that system, and it's incredibly important to recognize where the tension points are going to come from. And as long as we begin to do that and do that early, we're going to start to identify ways to reduce that risk, reduce those tensions, and then increase positive outcomes for ourselves. So I think that's the first thing. Remember, we're all part of the same ecosystem, so it's really hard to separate a health intervention from an environmental intervention because it shapes outcomes for ourselves. And the second thing I should say, and it really picks up on the Prime Minister's point, there are really simple, practical solutions out there. That's what we're hearing. That's what we're seeing. It's a question of scale. It's a question of consistency. I know we don't have all the answers, and there's a lot of work that has to be done. A lot of great groups are working on this. But where there are practical solutions and they're yielding benefit and they're simple, it seems to me the obvious thing to do.
Yeah, and just focusing the mind earlier, investing earlier so that we can check off many boxes of the outcome, which is simple for us to think about. Sheila, Prime Minister, thank you so much. Fantastic conversation.
Thank you, Maggie. Thank you.
Please welcome to the stage the Republic of Mozambique's Minister of Health, the Honorable Dr. UNGA80, and Food for the Hungry President and CEO, Mark Visso, for a conversation with journalist Stacey Samuel.
Good afternoon, everyone. So I want to just start by prefacing, we know we're living through an unprecedented era of overlapping crises, from climate disasters to conflicts to supply chain disruptions that are testing health systems worldwide like never before. While traditional health system strengthening focuses on building capacity for normal operations, today's reality demands something entirely different. Systems that don't function but continue to deliver care and adapt when everything around them is falling apart. So today, we are joined by Mark Visso from Food for the Hungry, an organization with over 5 decades of experience building resilience in some of the world's most challenging environments, including Mozambique, where they've pioneered approaches that go far beyond project-based interventions to create really lasting system change. And then we are very lucky to also hear from the Honorable Dr. UNGA80, Minister of Health for the Republic of Mozambique, who will share how his country is advancing innovative financing strategies to build health system resilience from the ground up. Together, they'll show us what it means to design resiliency in health systems. So I'm also going to say, because we have the privilege of having the minister with us, who's going to share his remarks in Portuguese, and if your Portuguese is not so good, I couldn't get very far beyond bom dia or boa tarde, good afternoon. They are providing us all. You will see on your seats that there is a device that is on. When the minister speaks, you will hear the translation, and this way we will all be able to be fully engaged. And if you are Portuguese speaking, there is also a channel just for you. So with that, why don't I start with you, Mark, from Food for the Hungry has been around, like I said, for 5 decades. And you've really been working in some challenging environments. When you look at the current landscape, crisis abounds, everything from climate disasters to conflicts in supply chain delivery. How has your understanding of what it takes to make a health system truly resilient and able to evolve?
Yeah, no, it's a great question. First, thank you to FP for having us all here and for you moderating this, and it's an honor to be here on the stage with you, Dr. Issei. So, Food for the Hungry has indeed been around for over 50 years, and we're an operational NGO, partnering and walking alongside communities. And our role is to design, develop, and deliver catalytic solutions that help communities and families and hopefully countries flourish. And through those over 50 years, we've learned a few things. Some of them have been hard lessons, and we've learned a lot in Mozambique. We've been in Mozambique for almost 40 years, partnering with the government and with communities there and other stakeholders. And one of the things we've learned is that 10 years ago, we were talking resilience, we were talking about food security. Right? And that was all the attention. And we've learned, we've realized, we've learned from others that all sorts of systems need to be resilient to be effective, to be sustainable, to make lasting, demonstrable, consequential change. And so market systems, food systems, of course, but most importantly, healthcare systems. And so one of the things that we've learned is that healthcare systems has really, over the last 20, 30 years, focused on efficiencies, technical competencies, getting it right, provision of adequate healthcare. But it's really forgotten, and it's no surprise, right? But they've forgotten about unintended risks, stresses, things that put pressure in a way that a healthcare system didn't anticipate, and therefore cause it either to collapse or to have to adjust, demonstrably not be able to function. And so I think what we've learned is that for resilient systems, particularly healthcare systems, you have to build in the identification of, anticipate risks, crises, struggles, pressures, whatever they may be, and then to develop capacities, both individual capacities and, more importantly, systemic capacities around three areas. One, really absorptive capacities. Right. Can you mitigate and adjust and not lose functionality? Still be able to deliver the services that you need. Second, you need adaptive, right? Being able to change and to look at different and diverse options of how to continue providing what needs to be provided. And last, transformative, change the equation, right? Create different types of solutions that weren't thought of. And what we see is that often, even when we do that, there's a real concentration on the technical side, and a good, resilient healthcare system, I think we've learned, and many of you know even better than we do, is the combination of the technical and the practical. Doctors, healthcare professionals, but also from our perspective, and I think as we've talked with the Ministry of Health, they also appreciate and have done a lot of great work in promoting that practical side of community health workers. There's an example back in, Typhoon and Hurricane Idai back in 2019 in the Sofala province where, people could not get to their health care that they needed. And community health workers, some that we trained, that the ministry and the government of Mozambique supported, were able to make those connections. There's a case of a mother named Maria whose son could not get to where he needed, and community health workers were able to diagnose the malaria and treat the malaria, and able to fill in those gaps that a highly technical, very good healthcare system didn't anticipate, couldn't fill without that practical application of community healthcare workers. So that's, I think, that really important part. Those three capacities, making sure you plan for risks and unintended disruptions, and blending the technical with the practical with community health workers.
Right. So really, it's leveraging the platforms that you have. You mentioned focusing on systems harvesting when we spoke. Rather than traditional project-based approaches, can you explain what that means in practice and how it's different from how humanitarian organizations have traditionally approached health system strengthening? Because what I'm hearing is you're really leveraging multiple platforms.
Yeah. I think that for Food for the Hungry, about 5 years ago, we embarked on a transformational journey, what we call reimagination. And I think now in the last year, we all are on a reimagination journey about humanitarian development looks like, right?
By necessity,
We just started a little earlier. And one of those things we learned is that we have to make ourselves deeply uncomfortable to sort of question and interrogate the mythology that we believed in that allowed us to keep going, and to say, why are things not working? Why do we have a $3 trillion annual gap to achieve the SDGs when we all signed up for it? We got to do something different, right? And one of those things that we've realized is that to really make a difference, we have to stop focusing on these linear, additive, transactional, temporal, a lot of adjectives, projects that do really good work, that are necessary and important, but are fundamentally insufficient, right? Is there a way that we can expand and look at and embrace systems practice? Map the systems that are at the root cause of why we have poverty, injustice, marginalization in the first doggone place. Figure out what are the different levers can be pulled. What are the scenarios? And generative AI can help us with this, right? What happens if you pull this lever or that lever? And then harvest the different solutions that come out of that systems practice. And then and you have to do this with community. It's really a partnership. And we're all learning it together. There's a couple of other organizations trying this. We're learning. We're piloting it in 3 countries, 3 different countries, trying it and seeing what it looks like. That's one thing. The second thing we're doing is around financing. How do we connect the dots? The traditional way is people give money. Food for Hunger is really fortunate to have 170,000 individual donors give their private money, but also government grants, U.S. government, European governments, multilaterals, and for a project. And we achieve it and measure it. But isn't there another way to leverage what we're all become familiar with? Platforms, Uber, Airbnb, to solve poverty that has the less linear, less additive, more dynamic, exponential, and multi-directional power of a platform that doesn't have to necessarily be directional, it can be curated. What could that look like? So that's what we're trying to play with. And we're doing a little bit of that in Mozambique.
Okay, so you've just shown us what resiliency looks like from the implementation side, working with communities and health workers on the ground. That feels like the perfect setup to set the stage for hearing from the Honorable Dr. Issei about how Mozambique is approaching this challenge at the national level, particularly around sustainable financing strategies. And this is a good opportunity to put your translation earpieces in.
Okay, thank you. Good afternoon, everyone.
Good afternoon.
I apologize. I'll speak in Portuguese. It is my native language. May I go ahead? Yes? Okay. Primeiro quero
I want to thank in the name of the government of Mozambique and our President of the Republic for the invitation to be here and to be able to share in a very humble manner and with much respect that which is our vision in the country as it relates to the theme that was proposed. I want to say that our goal as a country is to make the national health system resilient, robust, equitable, and just for our population. We want to build a healthy Mozambique, and for that, it is important to bring important aspects that I will speak later. As you know, the world is going through a great restriction in terms of finances. And this is truly a challenge for poor countries like Mozambique, who were taken by surprise. We were not prepared to respond to this global crisis in financing. But I also want to take the opportunity to thank specifically Food for Hunger for the great support that they have given to the people of Mozambique. So I want to take the opportunity to thank for this great support for Food for the Hungry in our country. Mozambique is a country that is located on the route of natural disasters. That is why our experience in resilience and on the approach of natural disasters, we were chosen by CDC Africa as the champion on the leadership of natural disasters. That gives us pride because we have experience, we have human capital, and we have responded to the situation. In the last 30 years, the country has registered over 45 typhoons, cyclones, and these winds destroyed a lot of the infrastructure, whether it was health centers, hospitals, and they put the population, making them poorer. Another important aspect is that the national health system in Mozambique has sub-financing that is chronic. It depends a lot on the support of their partners. There is a commitment of Africa. Mozambique should reach 15% of the budget for health, but unfortunately we don't get there. It's too little, it's not enough, and we can't respond quickly enough on this subject. Another important challenge that we face is the verticalization of external support. This verticalization makes the health system more vulnerable because the country has a plan and their priorities, and most of the partners have different priorities. So we're walking side to side and we don't reach the goals of the country. That is why next year Mozambique is going to present and implement the Lusaka agenda, which means one plan, one budget, and one report. All of those who intervene, whether from within or outside, will work to respond to what is the priorities of the country, to respond to the needs of our population. As government, we know that we have to reduce the inefficiencies and diversify the domestic sources and increase forecast for resources of health. We have pillars, which is the strategy for the financing that is going to bring many strategic actions so that we can have resources. On the short run, what we decided to do is establish a national dialogue on financing with the health sector involving all of the sectors, private, for-profit or not-for-profit. This national dialogue about financing will bring options, the main options on short, medium, and long term, so that the country may have local resources to finance their activities. The second important aspect that we are motivating the PPPs to assist, to strengthen our health system. At medium term, we're thinking about regulating the payment of the taxes. In our country, our health system is free, and nowadays it's not possible to maintain a system like that. It's just impossible to maintain a healthcare system that is free, strong, and resilient. And so we need participation of the communities, the population, to make the health services more robust and resilient. The third intervention is the health insurance that will be required, that we're going to introduce it in the country so that we can have better services. For that, we want to say that the actions that we're presenting here reflect our commitment with the country, with the financial sustainability, efficiency, and transparency in the area of health. We also want to reiterate our commitment with equity and the protection of the most vulnerable populations. For that reason, the strengthening of the subsystem in the community is highly important. The community in our country has a very important role. The health policy in Mozambique subdivides the health system into three categories: the public system, private system, and the community subsystem. So, as you know, poor countries, access to health is a challenging thing, and we're investing ever more in training and in preparing the agents of health at the community level. In our countries, they cover from 30 to 40% of the population. That is the first line of defense, front line. First line of contact with the population to deal with malaria, HIV, tuberculosis, respiratory diseases, malnutrition, which is a very hard problem in our country. So they're contributing for practices of preventions, good cooking habits, so that they can use their own resources to strengthen the population. And here, I want to highlight one thing. There is a political commitment that is very strong in the country to invest ever more in the community agents, because they have a very important role on the prevention, promotion, and also in the treatment of some illnesses. That is why we want to take this opportunity one more time to create a greater alignment in financing. That is one of the great challenges we have with the African countries. We have to align the financing, aligning the finances of the country, which is a domestic budget, but also the priorities of the external financing. If there is an alignment, we will have greater efficiency, greater answers, greater resilience for the health issues. As I said, in Africa, the greatest intervention is at the community level. That's the subprimary care, where we have the largest portion of population, and we have to use these community agents as the main pillar so they can integrate other actions. Mozambique is advancing because now the payment of the community health agents is done by partners, and I want to also thank our partners who have collaborated a lot with our country. The government of Mozambique is right now working on the regulation, a legal package, so that they may be absolved as employees or a workforce for the national health system. And that is a great gain, and at this time we have a national hearing of the importance of this agents, and the population is saying they're satisfied because they come from the community, answering the problems of the community. We reduced maternal mortality because they were able to quickly refer to a second level of treatment very quickly. We were able to save lives in terms of malaria, child mortality. There's results. So I want to take the opportunity to invite partners to help us bring more research in this area. It's an area that I want to invite you to help us to advance with research, bring scientific evidence to change policies, because the policies can only have success with scientific evidence. If there is no scientific evidence, it's difficult. So once again, I want to thank you for this opportunity to share with you what we are thinking to make the healthcare in Mozambique more robust, more efficient, more equitable, and more fair, above all, for the people of Mozambique. We want to build a healthy Mozambique, and that is why we want a single health in Mozambique. Government and partners, a single healthcare system to be more resilient, and stronger. Thank you for the attention.
Thank you, Dr. Issei, for this call to action. Mark, I have to pick up on what Dr. Issei was sharing, because when we're looking at traditional donor funding just declining, what the minister is sharing is that there is a need for public-private partnership to kind of help fill in that gap. Like, how do you see, like, innovative financing tools, you know, unlocking resiliency in these very fragile health systems?
No, it's a good question, and let me commend the minister for what they're trying to do, implementing the Lusaka Agenda, one clear, integrated program that allows us as other partners to know how to engage, right, and also to play the right role. That we're more catalytic than we are directive. That helps us learn together and figure that out. It all, you know, financing, of course, is a major component. As that plan shifts to having people pay for healthcare, it seems like a very easy solution, but it disrupts other systems. It disrupts, you know, the economic system. And so our hope is that as we look through what those new strategies for financing include, when they include health insurance, when they include people paying for the provision, that there would be a systems approach that would take a look at, if that happens, what works through the system, right, so that we can anticipate that. That said, I think that, you know, as we all see, a declining amount of investment in international ODA, which is development assistance. You know, there's an opportunity for the social impact investing world to step up. They've really coalesced around climate. There's some real measurable outcomes for triple bottom lines around climate. It's easier to quantify, less so on more, diverse sociological things. But healthcare is where I think if you go to the Global Impact Investors Network, they're migrating a little bit towards health because you can quantify health outcomes and get a double, if not triple bottom line on that. So I think there's an opportunity there. Can that go to scale? I'm not sure. But I think it's going to take a multiplicity of actors and tactics. And we would hope that it would be done not in a project-based way, but on a platform so that you can have different people that you wouldn't even imagine might want to be involved to exchange value in unintended ways, and also that social impact investing can unlock some of that capital and have a platform to play on that's transparent and that allows everybody to get what they need.
Speaking of kind of learning from past experience and using platforms to inform different projects, Food for the Hungry, obviously has deep experience in food system resiliency. What lessons from building resilient food systems do you think might be applied to health systems, especially in, again, fragile, conflict-afflicted settings and in an environment where funding has declined?
Yeah, for us, it's three things: making sure that all the different actors focus on the same system. What does that look like? And so everybody has a voice in that. Local agency, local ownership. What does that look like? And Mozambique's doing that, right? I think we can all do more and really leveraging a systems-based approach. Second, building those three capacities we mentioned. Right. Absorptive, adaptive, transformative capacity, and then making sure that we don't forget about planning for things that we don't even know when they'll happen, but we know something like it's going to happen. As the minister has actually mentioned, Mozambique is right in the forefront of disaster after disaster. I was there during COVID and used your healthcare system, 10, 15 times for testing, and one of our staff got treated. A great healthcare system. And, we worked with communities who have just been hit by typhoon and disasters and civil strife. So knowing that that's going to happen and prepare whatever your plans are to anticipate that, and be able to adapt to that is going to be important. And then lastly, bringing together, which I know His Excellency mentioned, which is the community-based approach, that no matter how much money you pour into the technical proficiency of a healthcare system, if people can't access it in a way that's fluid, it's not going to serve its purpose. And there's a lot of ways to do that, and we're hopefully part of that solution. Yeah.
And working together, obviously, like you said, it's the top down and bottom up, and training people and creating that access. So I want to thank you both. Obrigado.
Thank you.
Dr. Issei. Mark, thank you for the work you're doing with Food for the Hungry. We have a very clear call to action. You know where to put your resources and your research and where to direct it. Thank you.
Thank you.
Thank you both.
Thank you. Thank you. Obrigado.
Next, please welcome Organization for Economic Cooperation and Development Senior Health Economist, Dr. Guillaume Dudet, Found Senior Medical Advisor, Dr. Rekha Kumar, and World Obesity Federation CEO, Johanna Ralston, for a conversation with journalist Maggie Lake.
I'm excited to have this conversation because I think it's a topic that's very much in the news and in the headlines, but I think we know about it, but maybe we don't know everything we need to know about it. So thank you all for being here. Dr. Kumar, I'd like to start with you and give us a sort of reality check of what you're seeing with your patients in your clinical work when it comes to treating adults with obesity. Are we making progress in shifting this and framing this as a medical condition versus a lifestyle condition?
I think we're making a type of progress amongst certain communities because of the awareness of medicine and the awareness of the effectiveness of new medicines. And this is new in the past decade, or even more recently in the past 5 years, where the message about GLP-1s has gotten out there. In a positive way or a negative way, people know what these medicines are, and they're seeing people lose weight. And so they are coming in with some understanding that there's a role of biology and medicine could work. Perhaps they don't understand why. They don't understand the inflammation and the medical risk associated with obesity, but there is awareness that there's a role for medicine.
From your perspective, talk to me a little bit about what you are seeing in the conversation, and why do we need? My mic wasn't working. I could have put my outside voice on instead, but thankfully there's some angels here. So what are we seeing in terms of framing the discussion, and why do we need to think about this in the context of NCDs?
Well, I think, first of all, obesity is an NCD. It's a non-communicable disease, but also it has, it's been tremendously fragmented. Like most complex issues, they sort of go through this very painful period of fragmentation and then one hopes coalesce, and obesity is very much in that place. But what we're seeing is kind of a mix of, I mean, an interesting phenomenon actually, where the arrival of therapies that are so powerful, not just for obesity, but for other non-communicable diseases, has almost asserted that it is in fact a disease for people who did not believe that. I mean, as World Obesity Federation, we've had a position around this for a long time. It's become abundantly clear as you start to understand what constitutes a disease. But there has been this very binary, it's a treatment versus prevention and disease versus risk factor mindset, which it has to be a both and. Also, I happen to believe that that food is a form of treatment. I live with a chronic disease, and part of I treat it with food. It's not about preventing it but with food, treating with medicine. So we're hopeful that this can help contribute to more holistic and integrated ways of thinking about not just obesity, but NCDs in general and potentially other health issues.
And thank you for both setting the table, because I think it's important to understand where we are, because I think we all had a different perception probably of this. And now, could you plug in the importance of having this discussion around UNGA and the timing so that we understand what's happening?
Well, I mean, we're here at our fourth high-level meeting for non-communicable diseases. So the first one was in 2011. I was here then when I was with World Heart Federation, actually. But yeah, this is the fourth one, and from an obese. So that is how are we doing? There was targets set back in the early, back 13 years ago. There was a kind of commitments around elevating all NCDs. As working in obesity, we feel we're part of this wider NCD community, and we're also driving a lot of the premature mortality, in particular from cardiovascular and diabetes, and particularly cancer too, a number of cancers. But so from our perspective, we're frustrated that the process isn't more elevated than it is in terms of NCDs getting the kinds of attention that something that is in fact now constituting 75–80% of deaths in most countries or more is not getting attention, and obesity in particular is just not. It's not been acknowledged in primary care, which means you have to present with a comorbidity, which could take years, and so we're condemning young people in particular to waiting a long time before they can get a diagnosis and start to get treatment for an NCD.
Dr. Dede, what is the economic case for, because we can't talk about this without getting into economics as we have all day. What's the economic case for the government to treat obesity as a systemic challenge?
Well, the economic case is really obvious, but what we have recently, analyzed and estimated at the OECD, we have not published it yet, that we have been doing amazing progress in the past 20 years in the control of a lot of risk factors, that are, leading us to NCDs, like tobacco control has been, improving in most OECD countries. The level of the prevalence has reduced. Similarly for alcohol consumption, etc. But so all these progresses are great, but are being completely offset by the rise of obesity. So that's really a topic that is extremely important, because whatever we do today, if we don't address this specifically with its own challenges, we will not get anywhere, because this is really taking us back in time. That's a really, really big findings for us.
And how can framing it that way help with sustainable investment? We've been talking so much about how to pull the needed investment dollars into this area, into many areas that need it, but how can this help?
Well, what we're trying to see is that besides the direct medical costs that are generated by obesity, it's also a bit major driver of absenteeism from work, a lower productivity, etc. So the economic case similarly is clear for us. We think that if we don't manage to reverse the trends and get back to the objectives that we were setting as an international community under control of some of the risk factors, like it's a 0.5% of GDP that we're losing every year because of that. So that's really compelling.
Yeah, that's a big, I see you shaking your head.
Yeah, we did. I mean, we did an analysis that we published in 2022 in BMJ that it's somewhere between 2% and 4%, 2% of GDP broadly, roughly, and with variations, but really doubling over the next 25 years in terms of cost of illness, lost productivity, all the things you're saying. I mean, so if we can think of it as GDP being one way to measure it across all countries, it's absolutely only an investment to put resources into addressing obesity early rather than allow the diseases that it's causing to take their course.
And we just had a fantastic panel about talking about the challenges, even though prevention is so obvious, the challenges that we face in terms of funneling money toward keeping people healthy as opposed to sick care, I think, as someone put it earlier. Dr. Kumar, what sort of investments or policy reforms do you think are needed most urgently? Like, what do you need to help with this issue?
I think more messaging centered around the science from the education level to the local government level to the policy level when we speak about this, rather than speaking in a way that we blame people or blame patients. I think centering it on the science that, there are biological contributors here. The environment matters, your genetics matter. So of course, food and exercise matter tremendously, but from the primary care level to the, teaching doctors, teaching medical students, I think the way we talk about this and centering it around the science would help people understand that obesity is an NCD, just the way the downstream consequences of obesity are NCDs.
Mm-hmm. Yeah. Jenna, how can we better integrate this earlier? So we're talking about the need for earlier prevention, and it's astonishing what you just mentioned about primary care, the fact that it's not recognized or even discussed. And I think that any of us who've been to a pediatrician can sort of attest to that. It's not really one of the things that comes up when you're going through the early checklist. How can we embed that earlier in the healthcare system?
Well, I think so first of all, thank you, and I totally agree with everything that Dr. Kumar said. But I think our hope is that we are looking ahead to a couple of years. There is going to be another big meeting on universal health coverage, and just to really finally embed obesity into UHC and just say this has to, and that does not mean embed medication. It means embed just a concept of obesity, which includes nutrition counseling early on. It includes, wonderful physical activity prescriptions, social prescribing, all those different elements and possible treatments. That's kind of a quick term thing. But I think to your point, there's so many healthcare professionals who do not have education in this. I was in China about a year ago, and I asked a group of doctors, how many of you got trained about obesity or even heard about obesity in medical school? Nobody raised their hand. Do you know how many people are projected to have obesity in China in the next decade? 400 million people. Wow. More than the population of the United States. And yet they don't get it, they're recognizing it, and they're doing it in this very fragmented yet, well-intentioned. I mean, they're certainly, government is recognizing this as a challenge, but it's just not been there. So finally getting it recognized as disease and driver of other diseases would solve so many of these problems and embed prevention into the agenda.
And provide coverage for the spectrum of care. So if we think of the spectrum of care as behavioral intervention, which includes nutrition and exercise, then medicine, then surgical intervention, right now what is reimbursed, at least in the United States, is the surgical intervention. So there are all these steps before. Yes, some percentage of patients would have still made it to the most expensive step, but all of the preventative steps aren't reimbursed by insurance. Doctors aren't incentivized to spend time on this. And so, again, nobody is acknowledging it till it's in its most severe state.
Incentivized. I like that word. It's a powerful one, especially when you're talking about economics. One of the problems that's come up, and it seems like it's the case here as well, is that you're dealing with countries who have this sort of immediate demand for resources and asking them to find the money to invest in something in the hopes it doesn't happen, which again sounds obvious, but it's, Prime Minister Clark explained very well the pressure of that. How do we get around that economic conversation or change the economic conversation?
Yeah, I think that we have also to not, get carried away too much, because we have a tendency to think that solutions to our problem can come from technologies or whatever they are. But so, I mean, the huge attention we put on medicines today is certainly not the thing that will get us out of this. If there is one, health policy issue or health topic that really advocates for the, health in all policies concept, that's really obesity, because it's really something that's a driver, that is driven by our environment, taken at the broadest and largest sense of the term. So really we have also to think that it doesn't necessarily cost things, or it's not about intervention, it's about thinking from the very beginning, how are we creating an environment that doesn't nudge us all individually and collectively into that direction. So that's really something we have to change our focal of reading, because decision makers, they really like, you come up, you have a problem, you have a solution, let's fix it. And it's really something that's really a broader issue. And that's this kind of, change in perspective that needs to happen. And that's why we have to advocate for that, saying it's really a perspective really that has to encompass all the elements of our societies and the way we drive our lives.
Dr. Kumar, it sounds like, so often we're faced with tremendous problems that we have to hope that someone innovates a solution to. It sounds like we have solutions that we know work here.
We have solutions on the expensive end. So right now we know the medicines work. But what is not expensive that could help a lot of people? And when you were speaking, I was thinking, well, what if we just stopped marketing junk food to children? That doesn't, who would lose there? Potentially who would lose is the food industry, who perhaps there's conflict of interest there. But if there's something that we could do that isn't so cost prohibitive to everyone, that impacts a lot of people, like pulling back junk food advertising to children, that is a place to start, and that is preventative. And I do think we'd see the downstreams of that.
You're shaking your head.
Yeah, absolutely. And sort of, ready access to ultra-processed foods. Diets have changed so dramatically in the last even couple of decades. That is absolutely a cost-effective, but it's very, I'm sure our friend from OECD could explain the complex embedded economics of what's driving that. It's driven by farm subsidies and all these different things that are making it seem like these foods are cheap, and they are cheap at some level to the consumer, but they cost the consumer and everybody so much more down the road.
Well, this is why we're having this discussion about this topic as a sustainability issue as well, and the intersection of that can be a powerful change maker. We talked about before, where does this fall, these topics, when you have a government, the health minister is making budgetary decisions. The agriculture minister is making budgetary decisions of their own. In some ways it's siloed, but I'm hearing you all say this is an issue that cuts across many of these topics. The economics behind that surely come into play.
But the thing is that we have to get out of the confrontational aspect of the topic. We can make it a win-win for everybody. Yeah. There is always a solution. For instance, if you take, in the case in Europe, we have the front of package labeling. What we have seen is that some industrials, they were ranked, so it's an A, B, C, D, E type of thing. So A is better and E is worse in terms of, what it brings in terms of quality of the food and intake, sugar level, whatever. It's really a complex formula to get there. But what we saw is that some industrials, they were ranked D or E, and by simply just changing the formulation of some of the product, they were moving towards, C or B. So this is a thing like we don't judge your, market shares or your economic interest, but if you feel that for your image, for your reaching your consumer and so on, and with small arrangements and tinkering, you can move towards. It's a win-win for everybody. So that can work. So we don't have necessarily, to be face to face. We can be side by side on this.
Yeah, which is how we should be thinking about this. Is there stigma that we have to overcome in terms of education? Because I heard you mention before having people, and especially patients, we'll talk a lot about patient-centered care. Is there still stigma that we need to overcome when it comes to treating and also finding the financing for this?
I think there's stigma in societies where obesity has been labeled a willpower problem, and being lean is, or thin, there's a cultural desire for that. But I don't necessarily know if that's true all over the world. I think that in the United States and Western Europe, where there's a cultural desire to be thin, there is stigma on people with obesity. But there are still parts of the world where we are seeing the shift from malnutrition to obesity within one generation. And I don't think that same stigma is there, but that's actually connects it back to, front of package labeling, where those are the communities, if we did that, I think there could be a preventative aspect. The stigma might not even be there, because if you're in a community where you still have malnutrition, becoming bigger, fatter, may be seen as richer and more well off. But it's going to another extreme where we're literally going from malnutrition to metabolic disease within a generation due to urbanization. If urbanization comes with fast food restaurants, let's do the, front of package labeling and put up the signs in the fast food places that have the warnings on sodium and sugar and fat from the beginning, rather than like us in the United States, we're having to undo all the damage. And from a scientific perspective, by the time the obesity becomes that severe, it becomes a brain disease. And so in the low and middle income countries that are still doing the urbanization pattern, before the obesity becomes the brain disease, can we do some of these larger, less expensive interventions that can be preventative? I think it's difficult to have the preventative conversation in the US and Western Europe because we're too advanced in the obesity, and we need to talk about treatment. But there's places we can still prevent.
And we can prevent cardiovascular disease and diabetes, morbidity and mortality. So it's a wider kind of prevention in the higher income countries. But I completely agree, and I think the cultural pieces make it's just another layer that you have to understand, because there's a lot of association. But I think of a South African patient advocate we have who is living with HIV and obesity, and she's having a completely different experience in the health system with long-term HIV versus a more recent overweight obesity, because there's understood so differently in that context, not just in South Africa, but by any healthcare professional in many countries. And there is a high association in some places, including among South African women, that higher weight means, your husband is rich and you don't have, you're not sick. You know what I mean? So there's a lot of different layers to this to get through. One other quick example I wanted to provide, just because I think it's really exciting, is in life insurance, they're looking at, there's some innovative things going on around childhood obesity and trying to help prevent that, doing programs to help that. And they're starting to show some results in that. And I think that's a great example of, to your point, where is this, let's not get philanthropic funding to do what we actually want the systems to be doing in terms of funding this.
Well, this is why we asked about how to embed it into the system, because
it's
otherwise again, it's after the fact, and then it's philanthropic, and then it's also later stage, and so then we're dealing with the instead of trying to get in front of it. As we close out, if each of you could give me just what you'd like the audience to take away from this, and why this needs to be addressed so urgently. Really, let's start with you.
Well, I'll get back probably to my first point. It has to be addressed urgently because first, when it happens, it's already not too late, but that's really more difficult to address, but also mostly because this is really pulling us down. I mean, as a global community, as I said, and if we want to really make progress and address NCDs, we really have to have a specific focus on obesity. And that's why at the OECD we've been publishing a lot in the past 5 years, because we believe that this special risk, it has a special place in terms of the risk factors we need to tackle and address, because it's not the solutions that worked for alcohol and worked for tobacco might not work for obesity, because it's really a much broader thing. So that's why we are really giving it a very specific focus and attention, because the toll associated to this is extremely, and the burden is extremely high. And if we want to build, prosperous, healthy, and safe societies, we will not be able to do that if we continue to carry 60% or more than half of our population who is overweight or obese in OECD countries. That's simply not possible. So it's really a public health emergency.
Public health emergency. Well put. Dr. Kumar?
So, although these medicines are very effective, if we don't fix all the other aspects that my colleagues are talking about in terms of the food supply, how cities are planned and designed, public policy, our bodies are going to figure out how to gain fat around these medicines. The human brain is adapted for survival and fat storage. We right now put billions of dollars into discovering some of the most miraculous medicines, but if we don't fix the upstream issues, we are going to lose our chance to effectively use probably some of the best inventions in metabolic health in 100 years.
Yeah, and they are. Joanna?
So I think we're not going to prevent our way out of this. We're not going to treat our way out of this. We need to do both. And to your point, half the world is living with overweight and obesity, and yet it's still not understood to even belong at the basic healthcare level. So we're really leaving, well, we say we're leaving half the world behind. It's 4 billion people. Interestingly, Paul Gasol, the basketball player who spoke at our event last night, said it's actually leaving 8 billion people behind because we're all in this. It actually affects us all. But, so that's all.
Yeah, it does affect us all. I think we know that. I think we know that. Well, thank you all for shining a much needed light on this. Appreciate it.
Thank you for great questions.
Next, please welcome Ugandan Minister of Health, the Honorable Dr. Jane Ruth Aseng Osero, Head of Global Policy, Climate Action and Health Resilience at Foundation S, the Sanofi Collective, Daouda Diouf, and Council on Foreign Relations Senior Fellow, Dr. Prashant Yadav, for a conversation with FP's Dr. Maisha Alam.
Hi, everybody. Thank you again for joining us here in person and online. And thank you to this illustrious panel for a conversation on non-communicable diseases, which present amongst the most urgent and pervasive health challenges globally. Whether we're talking about cardiovascular disease, chronic kidney disease, respiratory illnesses, they exact an enormous medical toll, but they also cost economies exponentially every year. And so I'm really glad to have an opportunity to speak with all of you and to focus our conversation a little bit about the partnerships and the solutions that are necessary to ensure that NCD care models are making it to resource-limited settings and proving effective. Minister, thank you for joining us. It's an honor to have you here. And I'd love to start with you and ask you specifically a little bit about how you are seeing and tackling the challenge of NCDs in Uganda. What do you see as the most important opportunities at this time? And what are some of the challenges that you're trying to overcome?
Thank you very much for the question. Uganda has a growing burden of non-communicable diseases. And as many of you are aware, many African countries did not meet the Millennium Development Goals. So we have a dual burden of both communicable and non-communicable diseases. Now, in Uganda, 1 in every 4 persons may be hypertensive. That's about 25%. We have about a 3.3% burden of diabetes. We really don't know the prevalence of cancers, but we have a huge burden of trauma. That means in a very short time, Uganda will be overwhelmed by both communicable and non-communicable diseases. So we must act and act now. What opportunities do we have? Uganda cannot do these things alone. We do it in partnerships. And we are privileged to have a number of partners. One of the most important things in handling non-communicable diseases is to have a skilled workforce, but also a responsive community. So we've been working with Seed Global to train human resources, specialized human resources that can handle some of these non-communicable diseases at a facility level. And Seed Global has been training both specialized doctors and critical care nurses for various facilities across the country and supporting universities to scale up the training of the skilled workforce. We also have other partners that have been supporting us to strengthen the community health workers so that we have a system that starts from the community level. Now, the community health extension workers are trained for about 6 months and tooled with digital blood pressure machines, glucometers, pulse oximeters, and transport that can facilitate them to move door to door. So the system works in such a way that when you are identified in the community, there is a referral system. Again, the partners like Seed Global helping us strengthen the referral system. And you are referred from the community to a health facility where you will not only get care, but you will also be sensitized on what you need to do so that we can prevent. So the referral system ranges from the community to a tertiary level, where if your condition cannot be handled at the lower level health facility or a primary health care setting, then you become a patient that needs to be handled at a tertiary level where we have the specialist trained and supported through partnerships to give that critical care. The challenges are that we are adopting a more Western style kind of culture where people live a sedentary lifestyle. No exercise. The diet is a big problem. And the diet, of course, leads more to the diseases, but also lack of information propagates the problem. So we have a burden to sensitize the communities. And again, we are doing a lot of this through the community health extension workers, but we have also developed a nutrition plan for the entire country so that they can be trained. We are encouraging exercise for everyone. I think people have seen that Ugandans do a lot of exercise. We have a law against tobacco and alcohol. And we also encourage peer-to-peer, talk and counseling about that. Thank you.
Thank you, Minister. And there's so many threads that I'd love to pick up on with our other panelists. I appreciated your emphasis on workforce development and skills to adapt to meet these realities. you also talked about the importance of community level engagement and really that being the key to reaching individuals and identifying, patients and increasing awareness and diagnosis as well. Just picking up on some of those points, Doda, I'd love to bring you into the conversation and ask you a little bit about, how you are thinking about partnerships to improve the availability of medicines, diagnostics, preventative services, which the minister emphasized, especially in underserved communities. How does that work in practice in terms of what you are trying to do?
Thank you. I think the minister touched a little bit on that. I think partnering with local stakeholders, those who know where communities are and how to reach them, how to talk to them is critical. So partnering with local organizations, CBOs, and really investing in the capacity development and supporting community health workers is key, because if you look at the health system in Africa, the backbone of the health system is community health workers. Mm-hmm. So it is important to collaborate with community health workers and the health workers. But when we were working on infectious, on HIV, TB, malaria, you used to say, know your epidemic, know your response. So if you really want to know how to better intervene, how to better deliver services for NCDs, you need to know what the NCD problem is. And the best way to know it is to work with those who are working directly with patients, with community, and how do you know how to deliver at the front door of every community and every patient the essential treatment and the essential services. We have a big problem of health workforce shortage. We have also those who exist are not skilled and trained enough. I think investing in the training and the capabilities of community health workers, as well as the decentralized health facilities to be able to deliver the essential services to community where they are, using mobile health services is extremely important. And for us, it is also the partnership we need to develop. It's also about how we can get the best innovation and the newest innovation. Because when we talked about Africa or low and middle income country, it's often that we think that even the old technologies, that this is what we need to fix the problem. No, we need the best and the newest technology that can deliver the best services to communities at community level. And working with community health workers will help us to adapt the services to the needs of the communities, particularly where there are needs that are unmet.
And meet people where they are. Yeah, absolutely. And again, reflecting on what the minister was talking about earlier, and Doda, you alluded to this as well, which is the critical role of two things. One, strengthening primary health care systems, because that really is the front lines in many ways, right? But the other piece of it is also, and the minister, you were alluding to this, which is taking a life course approach. It's changing behavior. It's raising public awareness. It's getting people to take ownership of their health. So building on some of those threads, Prashanth, you've been doing research on these issues for decades. You know a great deal about how health supply chains work as well. And I know much of your work has focused on really shifting the needle, so to speak, in the most under-resourced settings. So tell us a little bit about kind of, what you see as the key barriers at this point that are holding back NCD care delivery, and what you think is necessary, whether that's in terms of impact investing or cross-sector partnerships, in order to overcome those persistent inequities.
Thank you. Thank you for having me. Thank you to my co-panelists. I want to start by saying that we have to be very pragmatic and accept that country governments have limited budgets to even maintain coverage for therapeutic areas and diseases which they currently cover. A rapid expansion into NCD care is something that is fiscally difficult. In that environment, we have to accept pragmatically that there are patients who will continue to seek care in the out-of-pocket market by paying out-of-pocket to get NCD medicines. It's not a favorable outcome. It's not a desirable outcome that we want, but that's a practical reality. So we've got to accept that and say, what can we do to change so that a patient who goes to a private pharmacy, a private clinic, also gets high-quality medicines, gets medicines that are affordable. And that gets very quickly to the question of price. Now, we oftentimes, when we think of price, we think about price at the manufacturer. The reality is that the big wedge between X factory price and what a patient pays at a retail pharmacy is huge. Many times, hundreds, sometimes 500, 1,000% markups in between. The reason that happens is that manufacturer sells the product to an intermediary, who then sells another intermediary, who then sells another intermediary, who eventually may sell it to a retail pharmacy, and each of them has a 100% or a 50% margin. We have new models that have come up that are changing the status quo. There are at least 10, 12 companies that have used technology to disintermediate the supply chain, go more directly from the manufacturer to the retail pharmacy or clinic, thereby making the markups go away, but also ensuring quality better, giving us better data visibility. All of that helps. We just don't see the multilateral system, the governments in some countries adopt a partnership with such new players. I'm talking about companies like M-Pharma, MyDava, MyShameds, Kasha, Reach52. Many of them have built larger programming of this nature. So that's the first ask. The second thing I want to highlight is that in providing NCD care, one of the key aspects is how much is the budget needed and what is the quantity of medicines or diagnostics required or other health technologies required. So that comes down to forecasting, right? And we have spent enormous resources in getting better on forecasting needs for malaria medicines, for HIV medicines, for contraceptives, for vaccines. If you compare our forecasting models for NCD medicines, it is virtually non-existent relative to the resources spent on the other diseases. Without having a good forecast, we are talking in the abstract.
Yeah.
Minister should have clear numbers with very thin margins of error to say, this is what my program needs of this particular therapeutic area, perhaps even a product and a packaging type if possible. That helps the programming in the country, that helps the financing, that helps the manufacturer know how much is needed so they can plan better. There are models of partnership that are evolving around forecasting, but that is a second area we've got to emphasize very clearly and strongly. And a third is technology for diagnosis and screening is enhancing very, very rapidly, right? We can diagnose patients, or at least do initial screening, if not full diagnosis, using many new models of technology. Today, some of them are what people call as generative AI, but image recognition, taking pictures, the plethora of models that exist are huge. Once again, if you look at how large scale are they being used, is there significant government resourcing going into it? Is there significant multilateral partnership resourcing going into it? The answer is no. Right? That's another area where we can do a lot more.
Great. It's great to hear you talk about those opportunities and also kind of where things have really not changed in the way that they need to, and I appreciate that. We're close to being out of time, but I want to go back to something that the minister was talking about earlier, which is taking a patient-centered approach to care and really coming back to people and communities. And so this is a question for all of you, and I'll go to the minister first and then work our way down the line, which is, when we think about NCDs and specifically, to use the minister's words, prevention, right? Not just treatment and response, but prevention. What kinds of patient and community-centric approaches are needed in order to really have momentum in terms of NCD prevention? So, Minister, I'll go to you first.
Thank you for the question. First of all, we are all aware that all our diseases start from the communities. And it is extremely important to make the communities aware what causes NCDs and how it can be prevented, and make them own the systems for prevention. When they are part of it, then they will accept it. When they see the results, then they will be participants to ensuring that their own health works and works well. 2, we need to be very intentional about data and statistics, good records, because we need this for planning in real time. What kind of planning? We are planning for all, both for prevention and for treatment. And without data, you cannot plan appropriately, just like he was mentioning about the therapeutics. What do you need? What quantities do you need? What type do you need? And then we need to begin from simple measures that is acceptable by everyone. Simple treatments that is acceptable by everyone. So it is important that we have community guidelines for use in the communities by the community health workers, as well as guidelines for use at the tertiary level by those working, the skilled health workers, because that is another level of care.
Yeah.
Now, when we have guidelines for community health workers, they will not only carry out surveillance to find out who is where and who is sick, but then they can help to control whatever is happening at that level using those guidelines. So it is extremely important for the low and middle income countries to strengthen the community workforce to handle that. But it is also important to work in partnerships to strengthen the tertiary level because we need it. Actually, nearly everybody in this room may be a candidate for tertiary care for NCDs. Thank you.
Thank you so much. I know we're almost out of time, but Dauda and Prashant, let me see if you'd like to add anything to the minister's response.
Yeah, I mean, I think as she said, partnership is important because and coordination is also extremely important. Because what is happening now is a fragmentation. In the morning, early in the morning, the same community get messages or intervention from infectious diseases, from malaria, TB, and NCD, and whatever we name it. So I think there is a need for coordination amongst the stakeholders. We're all good willings, but we need a little bit of coordination to maximize the impacts we're having at community level. So that's one. Second, we need to increase our investment for NCDs because today, as we speak, only 2% of the fund for global health is going to NCDs. So we need to increase funding and financing for NCDs. And third, again, I emphasize the fact that training and supporting healthcare workers, especially community health workers, is key. And that's how we at Sanofi, we have been through our GSU program, been able to train over almost 30,000 healthcare workers, including community health workers, and we see the results. And I think working with community with that and tailoring our response with community to the needs, specific needs of community is extremely important to have sustainable impact.
Fantastic.
One thing I'll add to what the minister said is that I think we see in the global community a very strong emphasis and focus on primary care. We build the primary care systems, which is great. But at the same time, if you are the health sector leader of a country, you cannot shy away from the fact that in the short term, there will be a large inflow of patients coming for tertiary care because they will be in advanced stages of disease. And confidence in the health system is only built when you can care for the sickest of the sick of a family. If you do not have a working hospital which can provide care to the most acute patients, then any attempts you try to build on primary care will fall apart. So this cost effectiveness lens to say the only thing that's cost effective is primary care, let's build that, will fail. It will not lead to the confidence, at least on the access to medicine side. Our ability to fix availability of medicines at tertiary care facilities is easier because it's not the infrastructure challenges, but we tend not to focus on that part as much.
Fantastic. Well, thank you. Thank you, Minister. Thank you, Dauda, Prashant. Thanks so much for your perspectives and joining us for this discussion.
Thank
you. Now, please welcome to the stage Gates Foundation Deputy Director of Program Advocacy and Communications for Africa, Toko Elfikpule, for a conversation with FP's Andrew Solinger.
And we save one of the best conversations for last. Notice how I said one of. They're all very good at the end. I am super excited to be sitting down with Toko Elfikpule, Deputy Director of Program Advocacy and Communications Africa at the Gates Foundation. Thank you for joining us to bring energy into the room late in the day, which is what we're going to do. So, Toko, there's just like some small news coming out of the Gates Foundation this week. Not really a big deal. The foundation, and I jest, of course, the foundation made a major funding announcement for women's health. What excites you about it the most?
So this is the biggest investment the Gates Foundation has ever made in women's R&D. Fantastic. Because actually, crazily enough, not enough money goes into research and development for women's health. Globally, of all of the money invested in R&D, only 5% goes towards women's health. That's crazy, right?
That's terrible diversification.
4% on cancer and 1% for everything else.
Yeah.
So this was really the foundation signaling its commitment to addressing health issues that affect women. So it's really exciting for us because we feel that women all over the world are being listened to because women are so important for spurring global growth, for everything else. So investing in issues that affect women's health is just as exciting as it's ever going to get.
Fantastic. How about what it might mean specifically for women in Africa, women and girls, and development there? What does that mean to you?
So, unfortunately, most of us in Africa end up spending our weekends going to funerals. You know someone who's suffered a loss. And a sight which is becoming too common, too painful, is a sight of a young father in his early 20s at a graveyard, cradling a newborn baby and burying the mother of that child who would have died during childbirth. What would have been a most beautiful moment, welcoming the new arrival of a newborn, becomes the saddest day of that family's life. And looking at that baby, the child is going to be constantly a reminder of a life lost. And many women on the African continent, in fact, if you look at it now, globally, 700 women die daily due to maternal deaths. And many of them die due to excessive bleeding, dangerous bleeding during childbirth. So it's a side which is all too common, but it is so preventable. So really, this is just a matter of survival for most women, funding an area of work to save more women's lives and to give young babies a chance to be raised by their own mom.
That is very sobering, and maternal mortality is terrible, I know, in Africa. will a lot of that program be focused on maternal health? Is that your expectation?
Absolutely. I think because when you look at the announcement which was made on May the 8th by Bill announcing that the Gates Foundation will shut its doors on the 31st of December 2045. And within that, he made an announcement of what the foundation will focus on. Maternal health is amongst the core priorities of the Gates Foundation. So we basically are going to be doubling down on making sure that more children survive to the age of 5, more women live, particularly when you look at how many women we lose during child death. So reduce maternal mortality, eliminate infectious diseases, and support countries through economic prosperity.
Fantastic. So top of the list.
Absolutely.
When you invest in women's health, especially in Africa, it has economic ripple effects.
Absolutely.
Maybe you could tell us a little bit about those.
I think it's a no-brainer. I just really reflect on my grandmother and my mum. I was so proud to find a postcard of my grandmother. She used to sell flowers at the City Hall in Bulawayo. And she's there in the Bulawayo City postcard in the 60s, wearing a mini dress. And it's just amazing to see my grandma in that photo. Every time when I left school and I used to pass through City Hall, my grandma always had money. You knew that if you wanted to buy candy, your grandma had money. So it was just amazing that you invested in her. She paid school fees, she spoiled the grandchildren, but on a much more larger context, women and girls on the African continent, 1 in 2 people on the African continent are women and girls. So you cannot leave half your population out of your economic dimension.
You engage all the time with different actors in this play, government, civil society, philanthropic partners. You are a philanthropic partner. What does effective collaboration look like in practice? And maybe you could share an example, whether it's a program that Gates works on or not.
I think it's about recognizing the strengths of what each partner brings to the table. So I just talked about an example here where you have women dying unnecessarily from preventable causes. You have investments in research and development, money put in to invest in new solutions. But that solution will stay on the table unless the government effects a policy that includes it in its health package and makes sure that it reaches every health center in the remote communities. So everybody has a part to play. It's about understanding who plays a part in ensuring we've got resources, who plays a part in ensuring that we can take things to scale, who plays a part in ensuring we can reach the hardest to reach communities, who plays a part in ensuring that these things are embedded in policies and get delivered. So each partner plays a big role. And of course, civil society plays an important role in advocacy. So everybody has an important role to play.
Fantastic. You know, there's been a lot, and it's wonderful that Bill is leading the charge and Gates Foundation is leading the charge on this, which is great. But there are a few philanthropies that are doing so similarly. But generally, worldwide, especially from a government perspective, women's issues, health issues are, I won't say some of them are being actively downplayed. Some of them are just falling down the list of priorities, considering everything else is going on in the world. How can we ensure, what is the best way to ensure that women's health stays near the top of the agenda and doesn't get sublimated by financial crises, geopolitical competition, war, and other great worldwide medical calamities, climate change?
I think the more we can share examples of what's actually working well.
Yeah.
Because sometimes people need to see it to believe it. They don't really understand the numbers and everything like that. But I think if we can really show what happens practically when you save a woman's life, what does that mean for the community? What does that mean for a family? What does that mean for the country? So if we can really show and talk about it and really showcase these excellent examples of when everybody comes together towards women's health.
Yeah. Okay, great. So let's say we have policymakers, investors in the room and online right now. What are some top takeaways you want to leave with them on the prioritization of women's health? Why that's so important?
So investing in women's health is really a smart investment. It really is. it is not something that we should be thinking about as an optional. I think it is a necessary investment to spur economic growth. I remember, you know, when my mom was sick, we were all miserable in the house, right? When your mom is unwell, you drop everything that you're doing.
The mothership is down.
The mothership is down. So we all have experienced it, and we know at different levels. When your mom is healthy, everybody is happy. So why not invest in what gives you happiness?
You know, it's true, and you can applaud to that, by the way. And we had Rockefeller's head of health, Dr. Naveen Rao, on earlier today in the program, and he talked about how in India, you think about health being, when you count up all your blessings and try and do it digitally, and health gets a number one. If you have health, it's number one.
Yeah.
All the other aspects of your life, education, financials, a big family, friends, those are all zeros you add on to that one. So you can wind up with $1 million or whatever units you like. But if that one turns into a zero, you have nothing.
Yeah.
And I'm wondering if you agree with that philosophy and that's the most important element.
100%. I think we all know, just to be here in this room, you need to feel good. You need to be well. You should be pounding the streets of New York this week, where this is the only thing you have to do. You need to feel good to be walking around doing your 20,000 steps in New York. You need your help. And then you can sit in these meetings and enjoy them because you feel healthy.
Yes, indeed.
If you were feeling miserable, you wouldn't be here now.
You've been to a lot of meetings this week, I know, and a very full calendar. Big announcement from goalkeepers on Monday night, which was fantastic. You seem like an upbeat person. What gives you hope? But beyond the goalkeepers announcement and everything that you're doing at Gates, what have you seen this week that you think is a positive and that is a reason for us to end this conversation on a positive note?
Yeah, I think people recognizing what they can each do in this moment of madness and crisis. I think I'm hearing conversations where people are moving from what others can do, but what we as individuals can do. And that gives me optimism. And I think also in this room, thinking about what you've heard, turning that to, okay, this is what I can bring to the table. This is my carrot, this is my potato, this is my onion contribution to the soup. All of us can bring something.
Delicious. Toko Elfikpuli, thank you so much for your insights.
Thank you.
Thank you. I'm going to close out. I'll see you in a moment. Great. So that brings to a conclusion our conversations this afternoon. Thank you so much for staying with us, both here in the room as well as online. We talked about a lot, and I'm going to let us go in a second. I'll just give you a couple of takeaways. Prevention, super smart investment. Smarter investments drive productivity, prosperity, and sustainable growth. Public-private partnerships are providing powerful emphasis in deploying NCD care models. Strategies on obesity need rethinking. And as we just heard from Toko, women's health is the core foundation for generational prosperity. And she talked about her grandmother, and look at what her grandmother hath wrought in Toko. Very impressive. I want to again extend a big thank you to Lily and the Gates Foundation, as well as our supporting partners, Food for the Hungry. Love that conversation with the Mozambique Health Minister, McKinsey Health Institute, Reckitt, and Sanofi. And thank you to all of our speakers today, certainly. We have another program. That's right, another health program after this one. It's in about 45 minutes. So absolutely, please do go out and grab a refreshment or light snack. And come back and join us. We're going to be focusing in on NCDs, which are critically important but don't get enough attention. There were some translation devices on the chair. Please do leave those there. We'll collect them and give them another try somewhere else. So thank you so much. Exit whichever way you like, and please do come back in 45 minutes for session 3. Thank you.